Welcome to our conference session titled Living with PNH. Thank you for joining us. My name is Lee Clark, Director of Patient Services, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of our corporate sponsors and the generous support of our patients, families, and caregivers for supporting the conference today. Immediately following the presentation, there will be a question and answer session. If you are participating online, please feel free to submit your questions at any time during the presentation using the Q&A icon in the engagement panel on your right. To submit your question or comment, type the question or comment in the small text box window, and when you finish typing, just hit enter. We'll do our best to get to all questions today. When asking questions, I do ask that you do two things to help me manage the incoming questions. First, submit your question all at the same time. Second, please do not share private health information in your question. Our expert cannot answer any specific questions related to your personal health care. Our expert today is Damian Laber. Dr. Laber is a hematologist oncologist, senior member and chief of the section of satellite oncology at the Moffitt Cancer Center and Moffitt Medical Group at Tampa General Hospital. He is a professor of medicine, the director of the Division of Hematology Oncology and the University of South Florida in Tampa. Dr. Laber earned his medical degree from the University of Buenos Aires in Argentina. He completed his residency in internal medicine at the Cleveland Clinic Health System, followed by a fellowship in hematology oncology at Baylor College of Medicine with electives at MD Anderson Cancer Center. His research interests have been devoted to translational research. It's my extreme pleasure to welcome Dr. Laber. Thank you so much for joining us today.
Okay, good morning, everybody. I'm sure you can hear me well. So thank you for being here. And before I start, I want to tell you that this is for you, not for me. So normally I let people stop me anytime and ask me any questions as we go along. I think because of the hybrid situation, I'm just going to keep going. But we're going to have a lot of time at the end for discussions, comments, and I am happy to answer all the questions as well as I can. So with that, we're going to get started. We're talking today about PNH. So many of you suffer from the disease. You might have family members that suffer from the disease. And people ask you, okay, what is that? Okay, so what would you say? So there is not just one definition for any disease. Nothing defines us. But if we think about PNH, PNH stands for Paroxysmal Nocturnal Hemoglobinuria. And that's just a name that stuck to us for a long time, but doesn't really describe the disease. So in general, we say it's a rare disease, very rare, okay? It is a disease that happens, normally manifests as breakdown of the red cells. And we're going to be talking more about that. That's called hemolysis. And it happens because the patients that suffer from the disease have a population of cells, so have red cells that cannot protect themselves against the complement system. So what happened, the complement system is actually one of our normal systems in our body, and they destroyed the red cells on our patients. And when these red cells break apart, they release the insides, which are usually the hemoglobin. The hemoglobin in our body carries the oxygen, and that can be quite damaging for the patient when these red cells are destroyed. Now, I suspect that most of you are not physicians, but I can tell you, even for physicians, this is a disease that 99.9% of the physicians that you will see know nothing about, okay? Because it's such a rare disease. So you had to go to specialists, and even with that group, you had to be to almost super specialists for them to understand the disease. But what I'll do is I'm actually going to walk you through the important parts of that. So bear with me. Now, many times when you go to a lecture like this, they tell you about some difficult science, and then they tell you a little bit about the clinical characteristics, and I'm going to go the other way around. I'm going to change the order. We're going to talk first about the patients. Once you know what's happening to the patients, then let's figure it out what we can do and why that's happening. Okay? So, who gets it? So if we look around this room, okay, not that this is just for patients and family, okay, but I will be included in that population, okay? My son will be included in this population because this affects young people, okay? So the median age in the 30s, 40s, something like that. And it's a terrible disease because that's a time of your life that you're quite active, okay? You might be having children, you might be starting a family, a new job, and traveling and doing things that you like, and suddenly you get hit by a disease like this. The good thing is, by being such a rare disease, it's only about maybe 1 to 10 patients per million people. So if we look at the U.S. population, anywhere from 400 to 500 million, well, we only have in the whole United States 400 to 500 patients, okay? And that's why you might be in a city in which, you know, there are more fingers in your hand from patients that have the same disease as yours. So that's why it's a very good thing that we connect this way. And what's the prognosis? If we look at a few years ago, the prognosis is terrible. Average life expectancy, 15 years. So if you are 30 and they tell you you're going to be, half of you'll be died before age 45. Basically, you're not going to make it to my age. Okay, how bad that is, okay? Terrible. Even if we look at, let's say, 5, 10, 15 years after they diagnose, so just after 5 years, we lost 20% of the people. Okay? If we follow them for 5 years, for 10, now we lost a third of the people. Okay? If we follow them for 15, we lost half of the people. Okay? This is what it used to be, and this comes from databases that we have been published in the late 90s. 10 years later, when we look at the publications, let's say 2004, it was looking about the same. Okay? The good thing is that after that, then science came up, new treatments came up. Today, if we manage those patients correctly, the life expectancy should be really, really close to the normal population. Should not change. So it's very important for all of us to see the people that can help us get the appropriate care, get the appropriate treatment. It's basically taking care of ourselves, okay? Because if we do that, then the life expectancy should be very similar to the normal population. So how did the patient present? What are really the clinical manifestations of these patients? Well, I started this at telling you that these red cells get destroyed in these patients, and they get complications from that. So when you destroy the red cells, the patient develops anemia. Okay, so anemia is basically low levels of red blood cells. When you have low levels of red blood cells, how are you going to feel? You're going to feel really tired. Why? Because your body will be working much harder to carry the oxygen. What the red cells do is they go to the lungs, they get the oxygen that we breathe, and they take it to the regular tissues. Which tissues? All of them. Okay? When they get to the tissues, they release the oxygen. And then they go back to the lungs, pick up more oxygen, and come back. Okay? In patients that have low levels of red blood cells, then what happened is those cells had to do many more trips just to carry that oxygen. Okay? All of us at some point have moved from one place to the other, from a house to the other. So if you move by yourself, how many trips you had to do carrying those boxes? But if you're happy to have family and friends that they help you, maybe in one time you carry everything in one load and so forth. So think about that. I'm giving you a few analogies. So that way you get an idea, and then you will understand, okay? Now, at the same time, the blood that we have is made at an organ called the bone marrow. The bone marrow is the organ that is actually inside the bones, okay? So the soft part of the bones. So that's what we have, what we call the stem cells that make all the blood, okay? So many times these patients have a disease that also affects the bone marrow. So they are not just suffering from the PNH, which we'll talk more about that, but they also suffer from maybe an immune disease that attacks the rest of the normal bone marrow. That's called aplastic anemia. Or they might have a myelodysplastic syndrome, okay? And it's a disease in which you might have other cells, almost like a cancer of the bone marrow. So they cannot build a normal blood. So they are having destruction of those cells, and at the same time they cannot make enough. So that's really a bad combination that they can have. And that has a lot of implications when we manage these patients, when we treat these patients. Now, when those red cells get destroyed, the inside part of those red cells get released into the circulation, and that's not supposed to happen. That's really, really, really toxic to the rest of the body, okay? Normally, when the red cells die, there are other cells that actually eat those, we call macrophages, and they take the cells and they recycle all of those instead of letting all these substances in the circulation. But in patients with PNH, they don't have time for that. The red cells get destroyed in the circulation, so all the parts that are inside get released, and those can be very damaging. And one of the most common damages that they suffer is all those parts stimulate the blood to form blood clots. It's almost like the body is saying, this is not supposed to be here, let's clot the blood, okay? So they get blood clots in the wrong places. Okay. This is not just somebody that, let's say have a surgery to operate on a leg. Let's say somebody breaks a leg and is bleeding, then you're going to clamp the blood vessels. So when you release the clamp, there will be a blood clot. That's expected because you're actually pressing on those blood vessels. That's not what happened on patients with PNH. Patients with PNH, they will develop a blood clot in any free-flowing blood vessels. So, for example, there is a vein that brings the blood from the liver to the rest of the body. Well, they get a blood clot there, okay? Because we call that Bad-Chiari syndrome, okay? So they get a blood clot in the hepatic vein. Or they can get blood clots in the veins that bring the blood back from the brain. So we call that sagittal vein thrombosis. So inside the skull, you get a blood clot. So imagine they can present with like stroke syndromes, okay, and so forth. So for us as clinicians, if we have a patient that comes to the hospital with an extremely unusual blood clot, we always test them for PNH, okay? The only reason not to test is basically lack of knowledge of the people that are seeing them. So we have to educate everybody that if we see these abnormalities that are so rare, then look for these rare diseases, okay? And then the other thing that happens, the muscles also get damaged, not just by that release of those products from the red cells, but also by the lack of oxygen because you're having less oxygen, so there is a full combination. And when we talk about muscles, it's not about muscles from going to the gym and getting stronger. These are muscles that we use to swallow food. So then people, when they eat, they feel that the food gets stuck in the esophagus, okay? So we call that dysphagia, okay? They can also develop severe abdominal pain because the muscles that move through the gut, they are not working well. Men can get impotence, okay, because the muscles also, they lack of the erections. So all of those get damaged, and they have really bad consequences. So you can imagine the quality of life of a young patient that has developed this without treatment. That's how they're going to suffer. Now, so what should I do as a physician when they come to see me? Well, the first thing is get a good history. So I asked him, okay? Because not everybody presents the same way. Some people might never have a clot, okay? But I need to know that because I might treat them differently. Some people might not have any problems with erections. They might do fine. Some people might eat well. They might not have pain. Or some might actually have all of it, okay? So we get a good history looking at all the symptoms and all the signs of the disease. Now, at the same time, I'm going to get some blood test. And when I do the blood test, I do what we call a complete blood count, looking for the signs of anemia. Then I look for markers of this destruction of the red cells. So on the chemistry profile, then we look at enzymes that get released like the LDH, that can get released on that. We also look at whether the bone marrow is working. So I want to see whether the bone marrow is compensated and making more red cells as they die off. And that's usually by measuring the reticulocyte count. Okay? So all of those we follow. Now, when we want to make the diagnosis, these PNH cells can actually be identified in the blood very easily. This is not a difficult test. Okay? The difficult part is to think about the disease and know what you are looking for. Because many people present with these symptoms and nobody does anything for that. They think, oh, it's going to go away. Okay? So they can sometimes go for years with complications. And it might take, it's very common for a patient to come and see an expert after they've been through 5, 6 years of symptoms and nobody could figure out what the cause was because they actually can look from something else, okay? And it's not anybody's fault, it's just this disease is very non-specific and it's very rare, okay? So imagine if anybody that comes with impotence, I'm looking for PNH, that's not really appropriate. So now, to make a diagnosis, as I told you, is quite easy today. We do a test called flow cytometry. When we do a flow cytometry, we actually have the blood, and we know that the blood has cells, and we have markers for the proteins in the cell surface. And if they lack the proteins that we know are lacking on patients with PNH, then we make a diagnosis. If they do have those proteins, we know that they are normal cells. Patients with PNH will have both. They'll have some normal cells and some PNH cells. It's like they coexist on that. And then we also look at the bone marrow examination. Remember that I told you that many of these patients have a disease that is affecting the bone marrow at the same time? So we always do a bone marrow examination looking for signs of what we call aplastic anemia, which will be some immune attack to the bone marrow, or for myelodysplastic syndrome, which will be more like a genetic involvement, and sometimes they can turn into leukemias and so forth. So that way I can treat them correctly through that. Now, we have several schemes on how we think through the process and how we make the diagnosis. I took this from UpToDate, which is a very common resource that we use as physicians. So we have an algorithm, and that's how basically we decide how and what to treat. But if you just pay attention on what I told you and you listen to your patient, then it's quite easy. So the first thing you do when we look at these patients, does the patient have also a bone marrow disease? And I know that in this foundation you also take care of myelodysplastic and other things, so, and aplastic anemia. So in this particular case, if they also have aplastic anemia or a myelodysplastic syndrome, then we treat for that, okay? And maybe the PNH will not be a problem, and I'll tell you more about that. At the same time, we get a good history and differentiate, are these signs of symptoms that the patient is suffering from just that bone marrow dysfunction that once I treat, they go away, or they also have the signs of symptom of PNH, maybe I had to treat both, okay? That's roughly how you make a decision. And if the bone marrow disease, like the bone marrow failure syndrome, is very severe, then if they are good candidates for a bone marrow transplant, that's usually what we're going to try to do. because that will be the only way we can fix the problem. We don't have a cure for this disease. But if we do a bone marrow transplant from somebody else, we call it an allogeneic bone marrow transplantation. Basically, we wiped out the previous bone marrow. We also wiped out the PNH cells, and we give them a new bone marrow, and usually they end up cured from this disease, okay? We had to balance the risk and the benefits because bone marrow transplant also has a lot of side effects. Not everybody can tolerate, so I'll tell you more about that. But roughly how we think when we see a patient is basically we look at both problems, which one is affecting them, and how can we help them, and which ones needs treatment right away. Okay, so the treatment that is directed to that PNH cells, remember those cells are the cells that are having a lot of destruction, okay? We try to stop that destruction, okay? What we call that hemolysis, and I'll touch a little bit more on that because you will understand once I give you the science, now that you can picture the patients. You see the difference? That's why I started the other way around, okay? And then if they have blood clots or if they have bone marrow failure, again, we talk about whether we will treat for that and whether we're going to take the patients to the transplant or not. Now, if the patient is coming with blood clots in very abnormal places, we have realized that there are what we call blood thinners. These blood thinners are being used for multiple problems of people that have blood clots or they have risk for blood clots. They do work, but they don't work really well on PNH, okay? Because if a patient with PNH develops a blood clot and the only treatment they receive is blood thinners, most of them will have a relapse. They will actually have, even when they take it, and some of the physicians say, well, are you really taking them? They talk about compliance. And you can have a patient that is extremely compliant, takes all the blood thinners at the same time, and still keeps having blood clots. Why? Because they are caused by the PNH. So the only way we can do is, so today, if somebody comes with blood clot, that will be an indication to start treatment and try to block that complement system. And I'll tell you more about that from keep destroying those red cells. And again, the indications for stem cell transplantation or hematopoietic stem cell transplantation in PNH, okay? Normally, we take them all the way in patients who have severe aplastic anemia, okay? In myelodysplastic syndrome, it's in a case by case because the results can be difficult to quantify, okay? So we also need a suitable donor because if we don't have somebody else that had a donor, the donors have to be quite close to the recipient. If the bone marrow is quite different, what's going to happen is it's either not going to take, so it's not going to be able to grow on the new place, or when it grows, it's going to attack the host, basically, the patient, and give them what they call graft versus host disease, and they can be very sick and even die from that. So that can be quite dangerous. So we really need to look for a good donor. And finally, they really have to be medically fit. So we now test them for cardiac disease, for lung disease, liver, kidney. So the rest of the organ function has to be in almost optimal conditions to tolerate the bone marrow transplantation. So most of the people are not candidates based on some of these criteria. But when we have a good candidate, and if they have severe aplastic anemia or severe myelodysplastic syndrome, then we try to do it. Okay. So now you know how to take care of patients. Now you know how we think about that. So let's dig a little bit deeper about the physiology and some of the science and all that. But before that, we need to understand what normal is. Okay? So what are the red cells? Let's talk a little bit about the red cells. So the red cells, if you look at this slide on the top, you have the bones, and inside that are the bone marrow. That's where we make them. Once they mature, then they get out in the circulation, and those are the ones they call the erythrocyte, and they start the normal function. So the red cells, remember, they come from the bone marrow, they go to the lungs, get oxygen, they go to the organs, they release the oxygen. As they work, they get damaged, okay? It's almost like many of us. As years pass by, we're not the same as before, okay? Some of us get pain here, some of us get pain there, and at some point we get too old and we die. Nobody lives forever. Red cells are the same, okay? So they are doing their job. They work, and they use their own proteins, their own enzymes. As they keep using, they age. As they age, some damage can happen to them. And when they get old enough, they get taken out. Okay? That's a normal process. And the criteria for the body to take those red cells out differs in different ways, but there are basically some messages that get exposed into those red cells that can be detected by what we call the macrophages. The macrophages are the ones that clean all those cells. And what they do is they basically take those red cells, digest them, and recycle absolutely everything. So you don't throw away anything. You don't throw away the iron. You actually recycle and use it to make more red cells later on. So it's much better than what we do with a lot of the environment as humans, okay? So we need to keep getting better, okay? But this is a good process, and it's the normal process. A red cells, from the day they start in the circulation until they die, usually we say it's about 4 months, okay? 120 days, 100 days. So at any given day, so if the cells live, let's say the cells live 120 days, so any day I'm losing maybe 1% of my cells, and every day I'm making it 1%. You see what I'm saying? That's normal. PNH patients, unfortunately, they don't live that long. So those red cells, they only live maybe 30 days, okay? So to keep up, your body has to be working harder, okay? But this is the normal. So in general, those red cells, when they get destroyed, we call that the process of hemolysis. So hemolysis is the destruction of the red cells. And in an abnormal way will be sooner than what they were supposed to. If they get destroyed because they are old and damaged after 120 days, that's perfectly appropriate. But if they get destroyed before that, then that's not appropriate. So for example, this is comes from a cartoon from patients with other type of hemolytic anemia, but we can use it for this presentation. So at the bottom on the left, you can actually see what we call the intravascular hemolysis, okay? So let me see. Intravascular hemolysis, that actually you see this complement is C5b29. Okay, we're going to talk a little bit more about that. Okay, that will be why patients with PNH, they lose that and they destroy that. But the normal hemolysis will be when these red cells get taken by the cells that are in the spleen and some on the liver. That's a good thing. Okay, that's called extravascular hemolysis. The red cells get taken out by the appropriate cells and get recycled. If it get destroyed in the circulation, then it's almost like you throw all the garbage in the street. You're not taking it and you're not recycling anything. So it causes a lot of damage to the rest of the body. Okay, now you know the red cells. What's the second thing I'm going to teach you today? Maybe I'm not teaching you anything, but I'm going to talk to you about today. Is the complement system. Okay. Now, for regular physicians, if you say anything about the complement system, they're probably going to fall asleep immediately, okay? And they know very little. It's one of those quite difficult systems, and you'll understand why pretty soon, okay? But if anybody asks you what the complement system is, what is it, okay? So there are many definitions, but, you know, humans have been, you know, present for many, many, many years, okay? Way more than we can think. The complement system is actually one of the oldest, or we call it ancient systems, in our body that protect us from infections. So it's part of the immune system. We call it part of the innate immune system. The reason we call that means it does not need to be taught. Okay, so what do I mean by that? You don't need to give a vaccine to stimulate the complement. Complement system is always active. It destroys anything that comes from outside in general. Okay, and the only things that the complement cannot kill that is coming from, so when you have bacteria coming into your body and things like that, why do we kill it? Well, because we don't want to cause an infection. How does the complement kills it? We'll talk more. Why does the complement doesn't kill our normal cells? Because our normal cells have a protection against the complement. So if your normal cells have a protection, then the complement cannot kill you. Okay? But if you don't have that protection, then you get killed. That's PNH. So the PNH, they don't have that protection. Okay? So this actually is a group of proteins. They are constantly active in your blood, in your immune system. So you cut yourself, you do a paper cut, bacteria gets into your body, the complement kills it right away. You need to vaccinate people for that. The bacteria is always active. It's protecting you. Okay? It's doing its job. Okay? And how does it do it? Well, the complement, these proteins, one way is they just get stuck to the surface of these bacteria. We call that opsonization. Okay, and you'll see that usually with the complement protein 3, which is C3. So they coat those bacteria. So when those bacteria goes by some of our other immune cells, they say that's a bad cell. So oh, you're marking them. Take them out. Okay. And then the rest of our immune system goes and attacks and kills that bacteria. So opsonization basically marks those cells for the rest of the immune attack. Another way is actually by direct, almost like drilling a hole in their cell surface. So you have the bacteria, and the complement system gets stuck and opens a hole, and then the cells explode. Okay? That's called the membrane attack complex, or MAC. Okay? And that usually utilizes the complement proteins 5 to 9. And I'll tell you more about that. Now, the complement system is good for us, okay? It protects us. But if it doesn't work well, you get a disease, okay? So it's like most of the other diseases, basically part of your body is not working well. So if you have an inappropriate activation, so if your complement is constantly active too much, it's like you're living constantly under attack by an infection, okay? So the patients can get sick and they can get diseases. And there are actually different ways to activate the platelet, the complement. And this is when we show this to any physician, this is just a schema of how the complement look. So if it looks difficult from where you are, well, it gets even way more difficult, okay? There are at least more than 30 different proteins. They all interact with each other. And so it's almost like the life of one person. If your life is complicated, well, this is way more complicated, okay, the complement. But in general, when we have things that are complicated and we'd like to study those, we start to separate them and compartmentalize, basically, so we understand just a piece of it, okay, one part of that. We try to understand the important things that can affect us. So we call the classical, the lectin, and the alternative pathways. And you see all these C proteins, and those are the ones that will be active. But if you understand the first two things that I told you, so the complement by binding to those bacteria causes opsonization, and then those get destroyed, or they by the membrane attack complex then get destroyed. Now, how do we shut it down? So let's say if the complement marks some of my normal cells, okay? So let's say the complement proteins, they get stuck to my normal cells. So the normal cells have enzymes that actually cuts them away immediately, okay? That's the protection. So as soon as the complement gets activated, you want the complement to only kill the infection, not to kill the rest of the body. So it has to be tightly controlled, and that's why it gets shut down very quickly. It gets active and gets shut down. That's a constant process. Our normal cells have those enzymes that can shut down the complement in the cell surface. Okay? And those are the ones that we take advantage when we do our tests. We look for those. So if they're not there, they have PNH. If they're there, they're normal. So there are some diseases that have been described, and they are associated with different complement deficiencies. So today, as you know, we're talking about PNH. But there are other diseases called, atypical hemolytic uremic syndrome, hereditary angioedema, paroxysmal nocturnal hemoglobinuria, which is today. Some of the lupus patients have complications with that. There are patients that suffer from susceptibilities, different infections, because they are lacking these complement proteins, and they don't activate really well. So some of them, they can get different respiratory infections and recurrent infections. Different. This is a very incomplete list, and it's also outdated. Why do I say outdated? Our science and medical field and medical knowledge is probably doubling only in like every 6 weeks to 8 weeks. We double the information we have with so much research everywhere. So whatever I put today is already outdated because, even if I did it a few months ago or something like that, or whatever is written in the books, okay. But that's a good thing. So we need to keep learning and getting better. So now you understand what the complement system is. You also understand what the red cells are. Remember? So let's put things together. Let's talk about PNH now. Remember the bone marrow, when you make all your blood? You have a group of what we call stem cells. These are the ones that keep dividing and building the rest of the cells. Okay. What if one of them mutates? Not all of them. So let's say I have trillions or whatever number you can think of cells that are stem cells growing in our bone marrow. And they're all good. One changes. And that change doesn't kill the cell. Because some of them, they change and they die. Okay. But how they change and they still can survive. And they start to grow. One becomes two, 2 into 4. So I end up with a bone marrow that has a lot of normal cells and some abnormals. So it's almost like you look outside to any garden. You will see a lot of grass and some plants. Okay? They still grow together, okay, or some with. That's the same happening in the bone marrow. So the PNH cells is one group of cells. We call that a clone of cells. Okay? So these are cells that are still part of your bone marrow. They can grow, they can make blood, but that blood is slightly different. Okay? There was a mutation on that. Okay? So these actually can happen just randomly. As our cells divide, changes happen. So randomly, a PNH cells can appear. Okay, some people believe if we look at anybody, you can find a small population of PNH cells, and they will go away over time, or some will grow. Okay, we don't know. The ones that grow too much and cause a disease, that's the reason we're talking about these today. The ones that disappear and go away, we're fine. Okay. Now, at the same time, this can appear whether your bone marrow is normal or whether your bone marrow is abnormal. But if your bone marrow is abnormal, so let's say the rest of your stem cells have a disease like aplastic anemia or like bone marrow failure, okay, then the mutant ones will show up a little bit sooner or faster or things like that. So when they correlate or when they are together, then you have more problems. But it can happen again in people that have the rest of the bone marrow looks perfectly normal, or it can happen on people that have an abnormal one. The mutation that happened on these cells, it happens in a gene called the PIGA gene. Okay? So for all of you that enjoy my southern accent, southern because I was born and raised in Argentina, okay? So I will say it with my accent. So it's phosphatidylinositol glycan anchor biosynthesis class A protein. Repeat after me. No, you don't have to do that, okay? And that's responsible for the synthesis of what we call a GPI anchor protein. You can actually read what that stands for, okay? So we call it the pig gene and the GPI anchor protein, okay? And this is located on the X chromosome, okay? So don't think women have more because of that, okay? Because men still have one X chromosome, okay? So in this case, if that mutation happened on a man, you can understand that they will get, that cell will become the disease. But in women, they have two X chromosomes, but one usually is not working because they don't need to have both. So it's like a little bit of redundancy. So if this happens, they can still get the disease. Okay. So that's why you see it also on men and on women, because the other X chromosome is basically inactive. So this actually is a schema of roughly what a GPI anchor protein is. So what is an anchor? So all of you living in Miami, anybody has a boat? Okay. So if you want your boat to stay in one place, what do? You anchor it. This is exactly the same. So an anchor protein is because I want that protein to stay there. Okay. So what do? Well, I want a particular protein to be anchored to the surface of my cell. In this particular case, which one is the protein that I want to stay there? The one that protects me from the complement. Remember? So the red cells anchor that protection. Now, if you don't have the anchor, your body can make that protection. It's just you cannot keep it on the right place. So then your red cells are not protected to that. Okay? Now, these anchor proteins can actually anchor other things. So if you get it before you're born in all your cells, you're not going to make it. Okay, those babies don't. Usually they die way before it. They get a mutation in all the cells. But if your cells are normal and only a small population in your body develops this, then that gives you the disease. You see the difference? Okay. So you can actually see the membrane of the cells in certain schema here and the protein that is being anchored by this GPI protein. So if you lack that anchor, then those proteins will not stay in the cell surface, so those cells will not be protected against the complement. Okay. So now you understand how that. So for this PNH clone to really grow enough to manifest clinically. So if you have a tiny number, it's not going to show up. So you're not going to have it. Usually, the rest of the bone marrow have a disease, or we don't know. There are certain explanations. Some people believe maybe, because of the rest of the bone marrow has a disease, these PNH cells, they can escape some of that immune attack, so they have a growth advantage. Okay. Some theories think that it might just be neutral. Okay? So over time they grow as the normal grows, and they will show up. Okay? And some people think maybe the PNH have a selective advantage on growth. Nobody knows exactly. This is still research in process. But if you want the schema of what's happening, so let's say on my left side, you see all these purple cells, let's call them normal. Now let's say the orange one, you see, is different. Well, in this case, it's not like I want to be bad to the orange, but in this case, we're going to call the orange abnormal. Okay, we're going to call them the PNH. So most of the stem cells should look like the purple one. So maybe they can go the route on the top, and over time, the orange ones, they just don't reproduce and they die. So that can happen in normal people. That might happen to any of us that don't have the disease. Or they can stay quiet for a long time, and then in the future, if something happened to the rest of the bone marrow, they're going to show up. You see that? They have what we call a latency. Or the other time is they will grow faster than the normal ones, like in the bottom. All of those theories, we don't know which one is truth. What we know is some people manifest the disease. We also know that a lot of people actually find a PNH clone on the blood test, and a year later I don't find it anymore. So it went away. Okay? This is what we do on the flow cytometry. This is what I told you is quite easy. Okay, you see all these graphs all over. So normally what we do is we have the cells, we mark them with a certain protein, and if they all mark the same, they will look like you see on the top, you see a little orange circle on the left, all the cells look the same. You see there is no variation. Now, if you look at on the right side, then you see how instead of looking that orange all located in the same place, now you look like you have different populations. And if we graph them at the bottom, if you look at the middle graph, on the left side, when I mark them for the CD55, that's one of the proteins that actually protect us from the complement. So the CD55 is present on all the cells. But if you look at on the right side, as we go right, now you see populations that have very low level of that CD55. So the two proteins that we look are the CD55 and the CD59s. Those are proteins that are supposed to be on the cell surface, that they are anchored by that GPI. So if the GPI is not present, then those proteins disappear and those cells get destroyed by the complement. Okay? So the way the complement is written on the books and by schema, I show you another picture of the complement earlier today with all these dots and colors all over. Okay, this actually puts them into cascades. So basically you're starting at the top and you're going back. So this is all how we try to describe it. It's not what's happening on the patients. But normally we used to call it what we call the proximal complement and the terminal complement. Terminal is basically once it goes and does its function. Okay? So the terminal is basically anything after the complement protein 5. And that's the one that goes, activates C5 all the way to 9, so C5, C6, 7, 8, 9, and forms a membrane attack complex. Okay. And we use that schema because we're developing treatment against all these steps that have to happen for the complement to be active. And when we do that, we can actually shut down the activity of the complement in the vast majority, okay, or by a high degree. So, now that you understand the red cells, you understand the complement. So, if you look at the top, you can see basically how the complement will destroy the red cells in our patients. So on the top left, let's say the red cells, they have this complement protein 5 that activates the complement, that is being activated by the C3. And that forms them, and the second one, you see the membrane attack complex. Okay, it looks like a drill there or like a hole in the cells. And once that happens, the cells explode and get destroyed. You see the top line. Now, if I am giving them treatment and I shut down with an inhibitor of the C5, okay, then I'm preventing that destruction by the membrane attack complex. That was the first treatment that appeared, and we'll talk more about that. Okay. But I'm not blocking the C3. And the C3, what it does, you might remember at the beginning, and I said that, it causes the opsonization, which means it marks the cells for destruction. So then these red cells get taken out by the macrophage system. We call that extravascular hemolysis. So sometimes in some patients, when I block the C5, they do really well, and I don't have to do anything else. Okay. They can do that for many years, and they do perfectly fine. Some other patients, when I block the C5, then they still have the C3 activity, and that destroys the cells by different mechanisms. So now we actually have a treatment for the C3. So we'll talk more about that. And hopefully in the future we have treatment for many of the complement proteins, and I can give you different schemas and different graphs to understand that, okay? So again, this is just taking a tiny little amount of what really is happening so we can use it for a lecture, okay? So if we look at what's happening, so as this, you can see the red cells with all these dots all over on the top. So basically are marked by the complement destroying them. And as they are happening, then they are taken out by the spleen and the liver if they're covered by the C3. But if they're not covered by the C3, they can be protected for destruction, okay, from the C5. Let's talk about treatment. I'm going really fast, like I told you. I'm going to finish ahead of time. We're going to have a nice discussion and talk. But I'm covering a lot of ground. So I hope you guys are still with me, okay? So, PNH treatment. Remember, you already know how to diagnose it and find it on patients. You know the signs and symptoms. You know what happened to the red cells. You know what happened to the complement. You know why the complement is destroying that on these PNH cells. So let's talk about treatment. So the first treatment that came and became available in the United States was called eculizumab. Eculizumab is actually a monoclonal antibody. That's just what type of drug it is. You don't worry too much about that. Okay. The way it works, it basically blocks the complement protein 5. And it blocks it quite well. Okay. It basically goes to that C5, and then it doesn't allow it to work. Okay. So the study that led to the approval by the FDA was actually published in 2006. So that looks like a long time ago. Okay. 2006, published at the New England Journal of Medicine. And to prove that this is working, because we didn't know, this was a completely new treatment. Before that, we really didn't have a particular treatment for PNH. Okay. Remember I showed you the prognosis, that half of them were dead in 15 years? Okay. The prognosis was terrible, okay, for young patients. Okay. The only thing we could do is give them a blood transfusion where the blood was too low, and then hope that they were not going to get blood clots. They will get blood thinners if they get blood clots, but they get more blood clots. And they get kidney damage, lung damage, and other organs. So this one, because we didn't know whether it worked or not, then initially it was a placebo-controlled study. And because this is such a rare disease, if I want to do a study like this, I cannot because I don't have enough patients. Okay? Because remember, there are only 400 or 500 patients in the whole United States. Okay? You think that 400 or 500 will be just in Miami? Or in Tampa, where I am? No, many of them are New York, San Francisco, Boston. How many cities you have? Okay, you have way more than 500 cities. So you can have a whole city and only 2 patients. Okay, like that. So basically, they got together a lot of institutions, and all of them to agree to treat the patients the same way. Half of the patients received everything they were getting until then. So nothing changed because this was an experimental treatment. We didn't know what to do. Okay. And then they got an IV infusion, but they didn't know what they were getting. So half of them got placebo, and half of them got this eculizumab treatment. They did not tell the doctors either what they were getting because they wanted to know the truth. Is this really working or not? So you don't tell the patient. But the patients knew that half of them will get it, and they also knew that if this worked, they'll be able to get it after. Okay, so it's not like you're just an experiment or anything like that. Your goal is to get people better. Okay, but you don't want to also give them an ineffective treatment. Okay, so they receive the treatment. It's usually given intravenously once a week for 4 weeks, and then after that you start and you give it every 2 weeks. Okay, and as long as it works, since it's an incurable disease, you're going to treat them the rest of their life, unless they get a bone marrow transplant, they get cured with that. Okay. And what do they look? Well, remember this disease manifests by this bad anemia. So they look at stabilization of the hemoglobin. Hemoglobin is what we measure when we look at the anemia. Okay. And they also look at the other laboratory tests that I told you we do on the patients. And they have some questionnaires, and they ask the patients how they feel, and they have quality of life questionnaires for these patients. So they end up recruiting 87 patients, which is quite good. If you only have 400, you know, in the whole country, it's difficult. And when they look at the results, they were actually remarkable. So when we look at the efficacy, okay, so if you look at this table, basically anything that is on the left side, okay, is not what we like to see, and on the right side is what we like to see, okay? So you see the part that says favors eculizumab, okay? That's a good thing. When it says, this is the other one, this is the study, okay. So, before I take you to the next drug, okay, sorry about that, let me give you the results on these ones. From the 87 patients that happened, okay, the stabilization of the hemoglobin happened in 49% of the patients of eculizumab, which means the hemoglobin went up and remained up. So the red cells can live longer. In the placebo, none. Basically, the hemoglobin kept dropping and they needed transfusion. They kept dropping and they needed transfusion. They kept dropping and needed transfusion. I can keep going. But that's what these patients were suffering from. So at least half of them. The other thing that we look at, when we look at 26 weeks, okay, it's usually half a year, 6 months. That's the duration of this study. You don't keep them on the study for years, okay? If you find a big difference, you do it for 6 months, and if it works, that's it, okay? Because you're not going to keep people on placebo if you know that this is working, okay? So 0 units of blood. So basically, the patients that were treated on the eculizumab arm in those 6 months, before that, they were getting transfusions all the time. Not one. So the hemoglobin or the blood remained high and stay high without transfusions. The other ones, the ones on the placebo, in those 6 months, at least they received 10 units of blood in 6 months. So you can imagine that. So based on that, of course, they will show that they reduced the hemolysis, all the laboratory parameters improved, and the quality of life was much better. You can think it's obvious for this one. So the FDA granted the approval, and we start using it on our patients. Okay. Now, after that, 2019, so you're talking about 13 years later, we had improvement. The improvement on that eculizumab was with ravulizumab. Ravulizumab works exactly the same as eculizumab. Also blocks that complement protein 5. Remember the other one I told you we had to give it every week at the beginning, and then for the first 4 weeks, and then after that every 2 weeks. This one stays in your body much longer. Okay, it has a very cool mechanism in which you recycle the drug so the body can keep using it, which means you only had to give it every 8 weeks. So imagine for any patient that has PNH, instead of having to come to and get an IV and get an infusion every 2 weeks, now once every 2 months, only 6 times a year, okay? And the results were exactly the same, okay? So basically there was no difference. We actually did a study not looking for which one is better, because we know that the eculizumab was great, okay? And there was no placebo anymore. Basically 100% of the patients that receive eculizumab. And then from those, then we say, well, half will give ravulizumab, half eculizumab. And we find out that they work the same. We call that a non-inferiority study. So we have 2 options. Most of the time, we go for 1 dose every 8 weeks because we don't have the patient coming every 2 weeks if you don't have to. Okay, if the results are the same. Now, when we look at what happened, we also did some analysis, and I'll show you, this is more on the scientific part. Okay. On the top bar is actually the LDH enzyme. The LDH is the lactic dehydrogenase enzyme. It's an enzyme that we measure in the blood. It's a simple blood test. Okay. When you're destroying the cells, then the cells spill that into the circulation, so it's high. So that tells you there's a lot of destruction of the red cells. Okay. When we started the treatment, you can see how low the level goes compared to the ones before they started treatment. Oh, they're not in treatment. Okay. So we know that it's working, and we know that they have less degree of hemolysis, and we're getting almost no transfusion or much less transfusions than before. And when we look at the concentration of that complement protein, the C5, okay, you see the top bar? Okay, it's actually truncated. The normal levels of C5 is so high up that I couldn't fit it on the slide. But as soon as I started treatment, it goes so down, and it stays down all the time. Now, sometimes on the bottom, it's actually the curves of the complement protein 5, the C5 level, on the patients on the eculizumab. That we're giving it every 2 weeks. Sometimes it goes a little bit up. So the patients with PNH, sometimes they can actually have what they call breakthrough hemolysis. So basically, because the C5 might not be completely controlled. So it's a little bit more common if you use a drug that needs to be given more often, that you give a drug that lasts for a longer time. Okay. And then, well, these are also the parameters showing us the same thing. So I'm not going to. We did, the company that developed the ravulizumab did 2 studies. And both of them show that it's as good as the eculizumab. One was on patients that were already taking the eculizumab. We call it a switch. They offer them, do you want to stay on the same, because you're doing well, okay? Keep on the same treatment every 2 weeks. Or you can get the new one, but it will be once every 8 weeks. And some people get apprehensive, because if you think everything is working, okay, you know, even if they tell you that might be a little bit better. So that's why they did the study. It's called the switch study. The ones that remain on the eculizumab versus the ones that switch, they all did as good. So now we don't have that problem anymore. We have the answer. Okay. The new one, published last year. This is called pegcetacoplan. It was published in the New England Journal of Medicine, 2021. Pegcetacoplan is actually a medication that blocks the complement protein 3, the C3. Remember when I show you the C3 that is the one that causes opsonization and binds to those red cells? Versus the C5. So how can I block the complement a step maybe ahead of the C5? So they have a randomized study, let me see, and on patients that were on the eculizumab. Okay, from before. No placebo here, okay? It will not be acceptable because in the United States, if you need treatment, then we give you the best treatment. No placebo. So eculizumab is given to everybody. Now, when the study was designed, the investigators were afraid of stopping the eculizumab because if you stop it, then the PNH will be too active and the patient can have complications. So instead of that, they have a compromise. They say, we're not going to stop it. For 1 month, you're going to get both medicines together. So basically, the pegcetacoplan and the eculizumab, we call that a run-in period. So you get both together. And after a month, half of the patients continue on one, half of the patients continue on the other. So basically, you stop one. So you end up, half of the patients will end up being on the pegcetacoplan, half of the patients end up being on the eculizumab. Okay? And then they follow that for about 4 months, and then you can decide. Now, pegcetacoplan was not approved by the FDA. It was an experimental. But they said, if it works at the end of 4 months, we're going to allow the people that did not receive it, if they want to, they can get it. They can choose for participating on the study until it gets approved, okay? Which is quite appropriate for the patients. So this is what happened with the hemoglobin. Let me walk you through the top part. You see what it says, the mean hemoglobin level when they enter the study is 8.7, roughly when they start. Remember that I told you that that's where the patients were before they entered into the study. So they were on the eculizumab. The hemoglobin was 8.7. They were fairly stable. They were not normal. Normal hemoglobin for a woman is between 12 and 16. So this is 8. So basically, they have 2/3 of the blood that they're supposed to, or 3/4. Normal hemoglobin for a man is between 14 and 18. So 8.7 is about half of the blood that you should have. Okay. So they're living their life with half of the blood, doing twice the effort to keep up. Okay. So when they received both drugs, the pegcetacoplan and the eculizumab, remember, all of them were on eculizumab. That's the way they were. Hemoglobin was 8.7. They received both. Within the first 4 weeks, the hemoglobins went to almost 12, 11.9, which was remarkable. At that time, as part of the study, half of them stay on the experimental arm, which was the pegcetacoplan. Half of them went back to just taking the eculizumab. The ones that went back to taking the eculizumab, the hemoglobin dropped back to the 8 levels like they were before, because that's the way they were before. The ones that remain on the pegcetacoplan, the hemoglobin remained high. And by the end of those 4 months, there was a difference of 3.8 grams per, almost 4 grams per deciliter. So the ones that received the pegcetacoplan lived with a higher hemoglobin level. So that led to the approval by the FDA. So you have both options, okay? So the FDA also approved the pegcetacoplan for patients that have PNH, and you can choose. This is given twice a week, okay? It's not an infusion in your vein. It's given under the skin, okay? So it's given twice a week under the skin. And because it's given under the skin, you don't have to come to a medical facility. You can actually take it at home. So you get the medication at home, you keep it in a particular space, the company gives you all the protocols, they teach you how to do it. And it has to be given on a pump, because you actually have to inject yourself about 10 cc's, which will be a small cup of coffee. Okay. So imagine if you had to inject a small cup of coffee under the skin. You're going to get a bump, because that cup will be about the size. So you cannot go really fast. So they give you a small pump that takes about an hour, and you give it really, really slowly. So you can actually watch an episode of Netflix or Hulu or whatever you like, and put the pump, and an hour later, then it's completely injected. If you want to go fast, they give you 2 pumps, and you take 30 minutes, but you have to take 2 places. So the advantage is you do it at home, you don't get an infusion. The disadvantage is you have to do it twice a week. Okay, and you have to learn how to do that. Okay. These are actually a list of some of the new medications that have been under investigations right now. At some institutions, they might be available under a clinical trial. This is not a completely inclusive, okay? It's just a rough estimate, so don't take it, but it's blocking on different levels we call of study, like a phase 1, 2, or 3. And with that, I told you I was going to be ahead of time. And I'm going to stop right here. I hope this was helpful. And if you have any questions, comments, anything you want to discuss, I'm game for all of you. Thank you.
Thank you very much, Dr. Laber. We do have a few questions. We'll start with a question online. How do you measure extravascular hemolysis?
So we actually do laboratory testings, and we're not really measuring the intravascular, extravascular. We're measuring the byproducts. So normally, depending on which destruction of which cells are, so we estimate that patients that have extravascular hemolysis, because they recycle all those products, then you might see other things. You might see a little bit more bilirubin, you might see a little bit less LDH, you might see the haptoglobin, different things like that. With the intravascular, you might see more LDH, less bilirubins, and so forth. But it's not a perfect science, okay? In general, what we do is if somebody is well controlled with one of the medications and they're happy with that, we keep it. If it's not, then we consider switching.
Thank you. And part 2 to that question is, do you need to treat extravascular hemolysis if your hemoglobin level is within normal range?
Our goal is to improve the quality of life and prevent complications. So if the hemoglobin is normal, we have achieved a remarkable goal. So we're doing great. And then the answer is no. Once the hemoglobin is normal, we don't have to treat.
Thank you. Does anyone have a question in the room that they'd like to ask? Okay. Next question online is, how often do you need to have a flow cytometry once you've been diagnosed with MDS? I'm sorry, with PNH.
So once you get diagnosed with PNH, if I am going to treat because they already have complications, then it's less important to repeat the PNH flow cytometry because we know that it's large enough to cause problems and it's not going to change our management. In patients that we're not treating, okay, at the beginning when we make a diagnosis, we check it every 3 to 6 months. Once everything becomes more stable and if nothing is changes, we might start spacing things up. In patients that were never diagnosed with PNH, but we suspect that they have a high risk, for example, patients with aplastic anemia, then we do at least a flow cytometry for PNH once a year. So it really depends on whether we're looking for it so, but if we don't need to make any changes with the information, we don't need to repeat it.
Thank you. When should a patient decide to look into the option of transplant?
So the transplant, if they have a severe bone marrow failure syndrome, those are the ones that we will consider. So somebody with severe aplastic anemia or severe myelodysplastic syndrome.
If a patient is diagnosed with aplastic anemia and PNH, and how do you know which disease to treat?
So that was at the beginning when we were asking about the signs or symptoms. So if the only blood cell that is low is the hemoglobin, and the markers of hemolysis, which is the destruction, is high, I know that is the PNH. If the other cells that are made in the bone marrow are abnormal, so for example, if the white blood cell count is very low, and they start getting infections because of low white blood cell, if the platelets are very low, and they have bleeding complications, then I know that is the bone marrow failure syndrome causing the problem. And then we also look at the bone marrow. We actually do a bone marrow test, which is a bone marrow biopsy. And when we see that the bone marrow biopsy shows basically no cells or very few cells, we know that is the aplastic anemia. With PNH, you will actually see a little bit more cells than usually, not less, because your bone marrow is trying to compensate for the destruction. So it's not difficult for us to differentiate which one is the problem.
Thank you. Any questions from in the room? No? Okay, great. Well, that's all the questions that we had submitted online as well. So thank you so much, Dr. Laber, for sharing your time and your expertise with us and traveling from Tampa to be with us today. So thank you again. If you'd like to watch this session again at a later time, it will be available on the conference platform within the next hour by accessing this session, clicking on replay, or you can just navigate the on-demand tab in the platform hub. If you have any additional questions, feel free to send it to us at any time in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, or submit your question to our Facebook page. If you're watching online, please take a few minutes to complete the session survey. Your input is important to us and does help us with planning our future programs. We're now going to be breaking for lunch, and we'll be returning for our next session at 12:45. If you're participating online, please go ahead and grab some lunch, and you can also chat with others in one of our discussion groups. To find the discussion group on the platform, just go to the Community tab. There are several groups there that you can join to get to know others, and this is also an excellent time to visit our exhibit hall. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us, making us your resource of choice for information on bone marrow failure diseases. Our medical advisory board and team are always here to support you and your family, as we've done for the past 39 years. This concludes our session.